Hello and welcome, everyone. We'll give it a few moments for everyone to get connected and logged in, and then we will begin our wonderful webinar for today. My name is Janice Hansen, and Carlin Calloway and I are the co-chairs for the Colorado Cancer Coalition Survivorship and Palliative Task Force. And we are very pleased to have you join us today for one of the webinars that we are hosting on behalf of our task force and making it available to you so that you can share in the wonderful wisdom that is around us with our Dr. Sonia Okuyama. I'm trying so hard to say that correctly. So let me just tell you a little bit more about her and we can begin with the presentation. I'm very pleased to introduce Dr. Sonia Okuyama. She's the Division Chief of Hematology at Denver Health, Hematology Oncology, excuse me, the safety net healthcare system for the city and county of Denver. So she has been a practicing oncologist at Denver Health since 2011. She is also an associate professor at the University of Colorado School of Medicine. Born and raised in Peru, Dr. Okuyama completed medical school there and came to the US for residency training at the University of Texas Southwestern in Dallas. She completed her oncology fellowship training at the University of Colorado, centering her research on the supportive care of cancer patients, with a focus on underserved patient populations. Currently, Dr. Okuyama spends her professional career leading the Division of Oncology at Denver Health, where she sees patients. She also teaches oncology fellows rotating through the Denver Health Clinic. Her research endeavors have included local and national collaborations evaluating psychosocial interventions for cancer patients, as well as exploring better ways to provide genetic counseling and testing for underserved patients at risk of hereditary cancer syndromes. At home, Dr. Okuyama enjoys family time with her husband, Tony, a pulmonary and critical care specialist in private practice, and her two young children, ages 7 and 5. Welcome, Dr. Okuyama. We're so glad to have you here telling us about your research in disparities in cancer care. Thank you.
Thank you. Thank you so much for having me, and thank you everyone for joining us. I was asked to talk to you today about disparities in cancer care, and I am honored to do so. Our objectives today include to understand some key concepts in disparities in cancer care, to identify major factors that contribute to disparities in cancer care, and to identify strategies that we can all adopt to address these disparities. Now, my expertise on today's topic does not come, I'm afraid, from extensive research and publications in the matter. It really comes from an over 10-year accumulation of experiences in my clinical practice as a community oncologist here at Denver Health. And as many as you know, Denver Health is the primary safety net institution of Denver County. And even though we are not a public hospital, as many people assume we are, we still proudly hold as a core mission to provide care for everyone in our community, regardless of their ability to pay. So my street cred to give this talk to you today is my experience taking care of urban poor cancer patients. I would love to hear from others to bring in the perspective of disparities unique to rural areas, for example, something that I'm just not familiar with. I was talking to Janice earlier before we went live. I was sharing that I had given this talk several years back, I would say 4 or 5 years ago. And sometime last year in 2020, I agreed to give it again. And I mistakenly thought it would be no big deal since I would be just updating my slides with the latest data and research. But I was terribly wrong because the social unrest of 2020 and the Black Lives Matter movement in particular has fundamentally changed this conversation. I found that the slides that I had before were empty and meaningless. And I found that the message that I was really trying to convey was not there. So I'm still, not fully satisfied with the end product from today, but at least I hope it will start a conversation and raise awareness. We can start with definitions. Health equity is the ideal state, and it is when people, regardless of who they are or where they live, have the opportunity to live the longest and highest quality of life possible. Unfortunately, the reality is that what we have in our hands today are health disparities, which are differences in the incidence, prevalence, mortality, survival, and burden of disease within a population. For cancer specifically, even if this disease affects anyone, due to social, environmental, and economic disadvantages, certain groups bear disproportionate burden compared to other groups. Now, these groups can be defined based on any of these categories: age, gender identity, socioeconomic status, geography, such as urban versus rural, and any other. Today's focus will be primarily on, but not limited to, race and ethnicity. Since we are in definitions, what is then race? It is not a biologic category driven by genetic factors. Race is a social construct based on physical characteristics, the color of your skin, the shape of your eyes. This is a snapshot from the National Cancer Institute's website on the topic of disparities in cancer care from several years ago. The top row shows us concrete examples of how certain racial and ethnic groups are disproportionately affected by certain types of cancer. The bottom rows of circles list reasons why that might be so. We know, for example, that African American women tend to have a more aggressive type of breast cancer and are much more likely to die from it compared to white women. We know that the highest rates of kidney cancer cases and deaths occur among American Indian or Alaska Natives. Liver cancer seems to disproportionately affect American Indian and Asians. African American men, for example, are more than twice as likely as white men to die from prostate cancer, and other examples as well. The danger here, when we start learning about these disparities, is to start looking at race as a construct based on genetic and biologic factors that are driving these disparities. Nothing is further from the truth. The truth is that, as we said before, race is a social construct based on physical characteristics, but it also encompasses other factors such as healthcare access, socioeconomic factors, exposures, diet, physical activity, and the major omission in this slide, in my opinion, structural racism. The first circle is the fatal flaw of this slide. The first circle of this slide should be racism, plain and simple. Here in some more concrete numbers, if we separate by race and ethnicity, we see that Black men and women have the highest rate of new cancer diagnosis and highest death rates. The good news is that over time, we're starting to see a narrowing of the gap. The excess risk of cancer death in Black versus white dropped from 47% in 1990 to about 18% in 2017 among men, and from 21% in 1997 to 12% in 2017 among women. We see this predominantly driven in lung cancer cases because of the epidemiological shift seen due to smoking cessation. However, these differences unfortunately persist until today. Broken down by common cancer types such as prostate in the upper left, breast cancer in the upper right, and colorectal cancer in the bottom row, the storyline remains the same. Black patients continue to die at a higher rate than other race and ethnicities. What if we break things down by a different category that is not race specific? Is the story all that different? It may seem like it, but deep down it's really not. This slide is showing us that if you live in an area characterized by higher income, and that's represented by a dark blue dot, your 5-year survival rate for a cancer diagnosis is much better than if you lived in a poor neighborhood, and that's represented by the orange dot. So what does living in a good neighborhood mean? It means that I was able to secure a mortgage and actually buy a house in such neighborhood, a privilege that was not granted to many for so long due to redlining, which is a whole topic in and of itself. And that is an example of structural racism. It means that I probably have a job that gives me health insurance benefits. It means that the local hospital is a big fancy comprehensive cancer center with a fellowship-trained breast radiologist, for example, reading my mammogram. It means that the water that I am drinking is probably not polluted by carcinogens, that the air that I breathe is not polluted by a highway that's right next to me, or that I can buy fruits and vegetables because I was taught to eat more than boxed mac and cheese. Here, yet a different way to look at the same problem. How about disparities based on your insurance? In this slide, we see colorectal cancer prognosis based on insurance. Private insurance is a continuous line, and uninsured or Medicaid and Medicaid are in the dotted lines. And each color represents a stage. Red is stage 1, or the earliest colon cancer. Blue is stage 2, green, stage 3, and yellow, stage 4. If we look at the superimposing lines highlighted by the green arrow to the right, you will notice that insured stage 3 patients have the same survival than a Medicaid or an uninsured patient with an earlier stage 2 colon cancer. So as you have seen, disparities exist in many different contexts, depending on how you separate the groups. However, the disparities based on race and ethnicity are simply more pronounced and compounded on top of each other. And this is because racial and ethnic minorities are more likely to be poor, more likely to live in disadvantaged neighborhoods. They tend to be in poorer health, more likely to be uninsured, have less education, be more obese, have less physical activity, and in general have more barriers to access care. They also have high mistrust in the medical and scientific community. But more importantly, and certainly most difficult to measure, is the fact that racial and ethnic minorities are discriminated against, suffering from overt aggressions or constant microaggressions that undermine their trust in health and healthcare overall. So let me circle back to the slide from the NIH from a few years back, and to their credit, this infographic no longer exists in their website. It is critical for all of us today to break free from the racialized conceptions of susceptibility to disease that persist to this day. The worst outcomes seen in Black, American Indian, and other racial and ethnic minorities does not come primarily from intrinsic biologic or genetic differences. It comes mainly from bias, prejudice, and stereotyping by the healthcare community. I've found the best examples of racism in medicine and social media, though these instances show up in the news as well. So here are some examples of racism in medicine. To the left is a tweet from Dr. Coleman from several months back. She is a phenomenal, fabulous trauma surgeon here at Denver Health. Her husband is a former NFL pro football player. He's African American, and he was out of state and got into a car accident and was taken to a local level 2 trauma center. So they called Dr. Coleman to let her know her husband was being discharged. Little did they know that Dr. Coleman knew exactly what kind of evaluations they should have offered to her husband given the circumstances, of which he got none. She raised up a storm and was able to get him the care he needed. So how many other patients don't get what they need because they don't have an advocate like her? This is a recent tweet from her reminding us what racism in medicine means. It's fewer diagnostic tests, incomplete evaluations, shorter hospital stays, inappropriate discharges, and fewer pain medications, among many other examples. Not too long ago either, a Black female physician died from COVID, but not after sharing on her Facebook page how she was being mistreated. And it was published on the New York Times. These are two flagrant examples involving highly educated, adequately insured, and not poor Black patients. Imagine what is going on with those who do not have an advanced degree, are uninsured or poor. How many complain of symptoms and don't get the necessary workup and their diagnoses are delayed? How many don't even bother to seek medical attention out of mistrust of a system that has failed them once and again? I like this graphic, even though it's old. It reminds me that for many of my patients, their cancer is the least of their problems. How much harder is it to go through the cancer journey when you don't know where you will sleep tonight, when you don't know where your next meal is coming from, or how you're going to get to see the doctor? An added layer also missing in this old infographic is when you have to fight against racism. Racism, however, is not simply the result of individual private prejudices. It is also produced and reproduced by laws, rules, and practices that are sanctioned and even implemented by various levels of government, and embedded in the economic system as well as in cultural and societal norms. And we'll talk more about this. Here, an example of structural racism within medicine. This fascinating article was published in the New England Journal of Medicine just August of last year. It compiled a list of clinical algorithms we use every day in clinical practice. It had examples from all specialties identifying them as being racist. And here are the ones highlighted that pertain to oncology specifically. All of these tools have race as a variable. Again, coming back to the mistaken concept of race as a genetic attribute affecting outcomes. The equity concern in all of these examples is that by inputting Black race, Black patients are getting less care than their white counterparts. I would encourage you, if you get a chance to review this reference, it's actually quite interesting. With all of that said, we can dig deeper into this topic. So this is the oncology health disparities model that was proposed by Dr. Polite about 15 years ago and published on the Journal of Clinical Oncology. At the center of the model is the question, why is it that one group of patients is dying from cancer at a higher rate than other? This group, again, defined by race, socioeconomic status, gender identity, for example. The three components contributing to the answer are, do we have groups that are diagnosed at a higher rate or at a more advanced stage than others? Number two, once diagnosed, are they being treated differently? Or three, once treated, are they benefiting from treatment in the same way? We can bring this model to life by looking at any cancer, and in this case, I just picked colon cancer. Once again, Black men and women die from colon cancer at a higher rate than others. So we can tackle the first question. Are African American and other ethnic minorities being diagnosed at a higher incidence or at a more advanced stage? And the answer is most certainly yes. It turns out that when quantified, this top section contributes to about 2/3 of the disparities that we see. Early colorectal cancer diagnosis can be successfully achieved via screening colonoscopies. It will reduce mortality by 50%. Unfortunately, not every group gets colorectal cancer screening at the same rate. African American and Hispanics, for example, are less likely to get screened. Spanish-speaking Hispanics are even less likely to get screened compared to English-speaking ones. So what are the stories that I hear all the time in my clinic? For example, I didn't have a primary care doctor, or I wanted to go see a doctor, but I don't have insurance, or no one told me I needed a colonoscopy. Or for example, I told my doctor that I had abdominal pain, but no one believed me, or no one asked me about my family history, and turns out that this patient had a lot of colon cancer in their family history, and still, the screening was not appropriate. Or some folks cannot afford the procedure or take time off from work. In these instances, the whole prep is very intensive and takes a whole day prior. And if you have to work and are paycheck to paycheck, you can't just take time off from work. Or it's a homeless person who doesn't even have a bathroom to do the prep. Another story I've heard is I don't have anybody to bring me back home after the procedure. So people during colonoscopy get sedation, and part of the requirements is that someone has to drive you home. And if you don't have transport back home, then those folks don't get the colonoscopies many times. Others will share that they're just very scared of the procedure. I remember a patient who had experienced childhood abuse trauma and really was avoiding any type of intervention in her lower part of her, pelvis. And some people are just scared of what they would find. So just very sad stories, but these are the reasons why people don't get screened and get their colon cancers detected early when it can be more curable and have a better prognosis. Now, there is good reason to believe that there may be a component of a different tumor biology and genetics affecting this group. For example, colorectal cancer in Black patients tend to be younger and have more tumors on the right side and have more microsatellite instability tumors, which is more associated with genetic predisposition. However, the question is how much of these biologic differences are related to perhaps lifestyle and environmental factors such as these. Once a patient is diagnosed with colon cancer, we also see differences in the treatment they receive. So data shows that African Americans are less likely to receive standard surgical treatments and chemotherapy. Or based on insurance, for example, Medicaid and uninsured patients might be more than twice more likely not to receive adjuvant chemotherapy for stage 3 colon cancers compared to privately insured patients. So in other words, there's a lot of inadequate access to healthcare is what we're seeing here. And of course, there are other factors as well, such as medical comorbidities and mistrust of a system. A story that I frequently hear in my clinic is an uninsured patient, or even one with Medicaid, who recently got a colon cancer emergently resected, but could not get in to see medical oncology for adjuvant chemotherapy. They were told at whatever hospital they were trying to get care that they don't take Medicaid, or that the appointment as a Medicaid patient was several months away, essentially negating them the benefit of adjuvant chemotherapy and placing them at higher risk of recurrence and death. We can't blame individuals about this problem, though. It is not the clerk who was answering the phone looking at the scheduling system. It's a system that is inherently biased against poor people, since we all know that any practice that takes Medicaid patients will lose money doing so. So again, another example of structural bias and racism is set up for failure. On the flip side, we see many good stories as well. One in particular that I remember very well is a patient I had many years ago, and he had completely decompensated schizophrenia, and I was seeing him for locally advanced rectal cancer. I remember thinking, how on earth was I going to do neoadjuvant chemoradiation, surgery, chemotherapy? He would talk about face and personality transplants, completely out there, and all sorts of scary stuff. At our tumor board, we were discussing, his case, and the discussion with the surgeons was like, gosh, we're never going to be able to do all the by the book treatment. We should just resect and forget about this neoadjuvant standard of care chemoradiation. But I'm really proud of my team who did not give up on him. With a lot of work and very limited resources as we have here, we got him connected to the necessary mental health services. And by going that extra mile, we were able to give him standard of care to his full extent. And his schizophrenia got controlled because we connected him to mental health. It wasn't easy, and this was done by a team who is already stretched out thin. Yet, my team, I'm very proud of, continue to rise to the occasion every single time for each one of our patients. We may not always succeed, but it is never because of the lack of trying. Once a patient is on treatment, do some benefit differently? Is the quality of the treatment different? Are they tolerated differently? And it seems that that is the case. I wanted to share an example of structural racism that was recently fixed within my institution through work here at Denver Health that I'm very proud of. And I know that other institutions are also following. Many of you may know, if you're in the medical field, that the way that we indirectly measure renal function is by getting a blood test called the creatinine level. And this is a key piece of information because it will tell us whether someone's kidney is working well enough to use a particular drug and what dose to use. The calculation of the creatinine level to kidney function, which is, it's a formula, turns out was inherently racist and apparently not based on biology. It's called the MDRD equation. This equation artificially gave better kidney function for the same creatinine levels in blacks compared to whites. So it artificially elevated the values of kidney function, and this basically translated in things such as delayed referrals to specialist care or a kidney transplant. In oncology, since it affects chemotherapy dosing, it was probably giving more toxic doses to African American patients. So it must have been spring of last year when all of the Black Lives Matter movement was really raging. There were a lot of hard conversations, internal conversations within Denver Health, and quietly they just got rid of this race correction for renal function from our lab reporting. And subsequently, I've seen publications about this particular issue on the medical literature, and I know that there is a push for other institutions to do the same. So again, not specific people being racist and being harmful to patients on purpose, but just certain structures in place that are in existence that, hurt certain populations more than others. As I mentioned before, the racial disparities in cancer seem to be decreasing. However, there is also concern that things may soon be getting worse. And this is because right now, while oncology is seeing incredible scientific advances, these are not happening for all patients. There is a lag in the implementation of medical advances. After all, more than half of Americans will get their cancer care at their local community oncology practice that is not affiliated to a big academic hospital or a medical teaching institution. A lot of these advances have to do with genomic medicine, and there is a disparate implementation of genetic testing. So as an example, Medicaid patients get their tests canceled or not covered significantly more than private insurances. And so then, a patient may not get a particular type of treatment because the genetic part wasn't looked at, or a patient who is on Medicaid didn't get a hereditary cancer syndrome diagnosed appropriately, and then their family members who are affected didn't get the necessary preventive services. And what's alarming is that the implications for disparities in access to genomic medicine, they really have long-lasting implications. It affects not only the patient, but the whole family and across generations into the future. So how do we move forward with this enormous problem? First of all, we start with what we're doing today. We learn more about it. We become aware that this is indeed a problem and that in some shape or form it does affect everyone. But then how do we move forward past the awareness part, and how do we actually fix this? And this is the most challenging part for sure. At the personal level, one thing you will hear very frequently in our clinic bullpen that can be easily translated anywhere you are is, if this were your family member, what would you do, to treat this particular patient? If this patient were the Queen of England, what would you do? And how can I go that extra mile for this patient to get them what they need? I believe in my heart that everyone in oncology truly and sincerely strives for this in whatever work or role they play in this field. But real and lasting change will require institutional, regional, and national policy change, and those are much harder to make happen. And if we achieve those changes, it will also require ongoing vigilance to make sure we don't go backwards. If we return to this health disparities model, the proposed path forward starts with access to quality healthcare. And by access, I mean, how do we make healthcare accessible and acceptable to those who currently do not have access to it? How do we make things like good food, clean water, clean air accessible to those who don't have it? So how do we improve access? And we can ask ourselves, is it true that my institution cannot do charity work? And in 100% of the times, it's not true. Everybody can do charity work. Or for example, is it true that my institution cannot take Medicaid patients, or is it just they don't want to? Or is it true that my company makes it extremely hard for certain populations to access their patient assistance programs and therefore the drugs that we sell? And what policies that we currently have in place are in fact part of structural racism, and can we change them? Like, one of the challenges that I have in my clinic, for example, is we rely a lot on grants from foundations just for things like keeping the heat on for our cancer patients, keep their electricity on. I mean, the forms for these grants, they are so cumbersome. If someone, like many of my patients, can barely read and write, a 4-page grant application is very challenging. Same with the drug assistance programs. I have to hire, we have on staff 2 full-time pharmacy technicians whose sole job is to get us the drugs for our patients. if it were easier, would I be using, the funds to perhaps hire a counselor to support my patients, or even a nutritionist to support my patients? Right now, insurance doesn't pay for nutrition support for oncology patients, which means that places with limited resources such as mine, like I don't have one. I don't have all these, extra income and funds lying around to be able to hire somebody to give nutritional support. So, all these things, of these random rules that seem to penalize poor people are instances of structural racism. And ultimately, in my mind, the bigger question is healthcare, in the end, a right or a privilege? I mean, why do we seem to talk all the time about healthcare being a right when the system is clearly built for health to be a privilege? Why aren't we all just comfortable, perhaps, with living in a world of health as a privilege? Where is this moral dilemma coming from? And these are very difficult and uncomfortable questions. I think that the scariest part of it all is how close everybody is to being part of the have-nots. All it takes is a cancer diagnosis for someone to lose their employment, then lose their health insurance, eat up all of your savings, be in need of Medicaid, only to realize that you don't have the same access to healthcare anymore. And I see that every single day, and it's tragic. The second part of the path forward, the one that addresses the disparities found in the receipt of treatment, is to provide culturally competent care. Culturally competent care is true personalized cancer care. And here we're not talking about matching the best fancy drug for the patient's tumor-specific molecular profile. It's more important than that. It is to identify all the needs of this person not a patient, this person who's receiving cancer care, and matching these with the appropriate resources. Within the continuum of cultural competency, the majority of healthcare lives in cultural blindness, where we do our best to treat everyone with the same excellent care. And while this is not inherently wrong, it is not enough. We all need to strive to move further up in our cultural competency, and this is achieved by looking hard for individual and cultural differences and engaging stakeholders from diverse groups to hire culturally unbiased staff, to train them, and to implement changes to improve services based on the identified needs. And finally, if the third component in the health disparities model is the benefit of treatment, the way to overcome this is through research. It is imperative to include underserved patient populations into clinical trials, so we can understand differences in tumor biology, benefit, and tolerance to treatment. After all, it is widely known that current clinical trials do not represent real-world patients. For example, clinical trial participants tend to be young and white, which is not what the real-world patient population is. Yet we're making medical decisions based on information from these clinical trials that are on patients who are not the real-world ones. Currently, less than 2% of cancer patients enroll in therapeutic trials, with the most important barrier being that they're just not offered wherever they are getting their treatments. Other reasons are listed here. And one last thing, as I read through the literature in preparation for this presentation, I was struck by the similarities between the proposed solutions to address disparities, as well as the proposed solutions to address the inefficiencies of cancer care. Because whatever we're doing right now is not sustainable, morally or economically. If we have learned anything during this pandemic, is that healthcare resources are indeed a finite resource, and we will drive ourselves to the ground by going on about business as usual without any meaningful change. And I love this one. To the left, equality, that's where most of us are, giving everybody excellent care, but equity means helping more those who need it the most. And that's it. I'm happy to take questions.
Thank you very much for that very informative and humbling presentation. Clearly, we have a lot of work to do, but also greater awareness through the research and your real world experience. I'm just checking our Q&A section and tab as well as our chat, and at this point we don't have anything specific that I see posted, but I want to certainly remind all of our participants today to think about what their experiences have been and how they might do at least one thing better. I think that's for all of us to think about with regard to how we stay informed and then put that information into action versus just retaining it for ourselves.
Janice, Joanne Poles had a comment about Project Angel Heart that does do meals for cancer patients.
Oh yes, and we rely on them tremendously. But there's still challenges in getting the meals to the patients. I remember a particular patient that, we kept setting it up and the patient never received stuff. And it was because, sometimes for people who live in certain areas that are not a good GPS address, things don't get to them. How do you say, it's like, oh, cross the railroad and to the left and there's this little shack, again, I understand my privilege. I've never had to worry about the roof over my head and, some basic things, but there's a lot of people out there who even their basic needs are not met. And then to do the cancer care on top of it is that more challenging. So I remember, that's just one example that comes to mind. But yes, Project Angel Heart is, gosh, a lifesaver.
Yes, and I really appreciate the information to remind us that the applications that we create for people to apply for these services are quite onerous with regard to their ability to read them in English, provide the information in a way that can be processed and used by that agency. And do you find that your social work team or other individuals or as navigators are able to dedicate the time to actually complete them with the prospective person versus just leaving it with that person to figure out on their own?
They can't do it on their own. At least with my patient population, they absolutely need the hand-holding. They do not understand these forms. The forms need to be at the 3rd or 4th grade reading level, and most of them are not. I have been having conversations with them of trying to lower it down, but it's something that requires sitting down with them, and that is a commitment of time for from my social worker to help them. And my lone social worker just doesn't have the ability. And I think that's where patient advocates, I see a question there, how can patient advocates help? I do think that there's nobody better than a peer, a cancer survivor, patient advocate that can provide that hand-holding and support so that people can get the help that they need. It might be easy for someone who has their phone and internet and they can download the app, but that is not the patient population that I see. That they have the cricket phones that, 1 month it's working, the next month it's not, because they didn't put money in it. And, to ask them to do these things, it's very, very, very hard. And then again, the patients that we see here, with those huge challenges, are served by a team that is really deeply committed, but at the same time, we are stretched out thin. So, for example, I didn't used to have a full-time social worker until perhaps 4 years ago or so. Before, it was one social worker for all of the medical specialties. It's, like cardiology, nephrology, like all the specialties, we shared one social worker. I probably have worked for like 10 social workers, but I only have one, but at least I have one and I'm very thankful. patient navigator is something that we typically don't have. And people assume, oh, you must have a navigator. So well, where am I going to get the money to pay for a navigator? You know, we rely many times on grants, but then grants require me to write something, and it's just, you know, like there's many challenges. And again, it has to do with the work that we do, which we're very proud of. You know, we're not here to make money off from patients and their insurance. And so, you know, yeah, we have a lot of Medicaid patients. It doesn't pay like the private insurance. And that means that there's no disposable income lying around. But again, that's a structural racism, right? Why is it that Medicaid will pay so little to whomever's taking care of you, such that then we are stretched out thin, and then the resources and the support is less? So, you know, again, this is a much bigger picture, and it requires change at the state level, national level, and, you know, things that I get overwhelmed with, you know, will require a lot of politics and laws and things like that. It's like, oh, I know how to take care of these patients. I know I do a good job, and I know that I have the experience, and I'm especially equipped for it. I know that it is not for everybody as well. There's a lot of people who, you know, will come through, like the fellows that we train, are like, oh, this is too much. You know, it does require a certain type of people to do it. But the team is there. And it's like, I would get care here because it's just a phenomenal group of people.
Yes. And I really like your emphasis on treating the person, not making them fit into our academic or structural system, but really listening to understand what they need and how we can meet their need without them expecting them constantly to meet our needs. So there are a couple of other questions that have come in. Is there a way to use or adjust current cancer risk assessment tools to be more equitable?
Yeah, and it is getting the race part out and really readdressing, you know, where do these calculators come from, and how and that work is ongoing for sure. But then these calculators have been in existence for decades, but it's interesting how now, with all this talk about the Black Lives Matter movement, you know, systemic racism, that now it's being looked at within medicine as well. It's fascinating, and it's encouraging to see that work is being done.
Yes, I agree, and hopefully we can have enough people engaging in the work so that it's shared by many versus a few. Another question is, what are some strategies for engaging in conversations outside of this type of forum? And are those best done at the patient level, the provider level, the healthcare community level?
I think the biggest impact will be probably at the state, national, that conversation. I mean, that's where it's going to end up being. You know, this whole question, is healthcare a privilege or a right? You know, that question as a nation will need to be answered, and then commit to it. You know, don't set up a system, but then be offended when, you know, things happen the other way. It's like, you know, just pick an answer and go with it. And that is, that's what I say, way above my pay grade. Because I truly believe that at the personal level, people do want to do the right thing. You know, when you talk to everybody, everybody wants to help. Yet that moral dilemma of people saying, oh, but my hospital doesn't let me, you know, see this patient. It's like, well, that's, you know, they're not letting you, and they put people in the middle of it. That's the problem of that institution.
Yes.
But then I think it's built that way for them. You know, they're just, that's the rule, and they're just playing the game.
Right. And those within the system sometimes have to educate each other about that because of that blindness, not really seeing it. And then it says, there's a comment here from Joanne Poles saying that a group of ladies are in the process of trying to fill this gap. We're in the process of completing a newly formulated foundation. So hopefully, and with keeping that in mind, they're making resources available that are much more accessible, that are at the appropriate level that people can actually understand and use them, and that the applications are written in such a way that people actually can complete them, or that there's some staffing available to assist. I heard of a new navigator role called a digital navigator that actually helps people learn how to use some of the technology that's out there. But like you said, when they have a smartphone, even if they're able to get one, they don't always maintain the service or even understand how to use it.
Yeah.
The next question is there any way that foreign medical graduates be involved as a non-clinical member of a team management? They are trained, they're skilled, and they can serve as cultural brokers.
Yeah, I love that question because personally, I myself, I'm a foreign medical graduate. I grew up in Peru, so my native tongue is Spanish. My grandparents are Japanese, which is why I look the way I look, but I consider myself Latina. And true, it is hard to break into the system, and then there's, a lot of people who really want to help. I think that hospitals just don't make it easy, honestly, for people to bring in the help. There's all these regulations and the HIPAA, and you have to get these training and health screen. I don't know. I think they overdo it. I understand why, though, but then I think it's a barrier. Places like Denver Health do have a wonderful volunteer community. It's like an army of folks that come and help out. And I would love to have volunteers in my area to help patients. For example, we have a resource center, but it's not like it's staffed, with someone in particular. It's like everybody just kind of, we pitch together and try to help out things. But I do think in my mind that place needs to be run by advocates and volunteers, because in the end, they're the ones that are closest to the patient perhaps and can help out. Right now with COVID, all of that was shut down. We couldn't meet or anything. So I'm really hoping that as we reopen, we do it in a more conscious way. Now, your volunteer opportunities are not necessarily related to, a healthcare system, right? There's also opportunities to connect with patients via other community centers. And I think they probably might be most effective, whether it's their local community centers or church groups and things like that. Those are also great places to volunteer.
Wonderful. And then as our task force moves forward for the survivorship and palliative care members, we are always interested in knowing, is there something that our membership or our task force can do to help further advance your work, this understanding, some integration of change that you see is available to each of us in our respective roles, either as part of a healthcare system or as part of a support program that provides services and opportunities for individuals with cancer?
I think that what this coalition is interesting is that it does have membership from, so many different places in the state. Again, I only bring a perspective of urban challenges, and, bringing to the conversation that rural side, access to, if getting cancer care means driving 3 hours, and there's that's poor access to, things like that. So it's a unique venue where you can really get a more complete picture, and I would encourage the task force to work closely with legislature to bring these matters up to the table and slowly move in the right direction. There's this quote from Martin Luther King that I love. What is the arc of justice is long, but it bends towards justice. So I do think that this journey is going to be long. There's a lot of competing interests, but then eventually I do think we will head towards the right way, and it does require that nudge and that advocacy from groups such as this one.
Yes. And I would imagine the personal decision for each person to make this a priority in their work rather than um, relying on our group or our organization. We have to begin with ourselves and recognizing this is an issue and doing something about it.
And it's interesting because during this pandemic, I think people have made those conscious decisions, right? For example, you know, with the economy shutting down, all the restaurants, you suddenly are thinking, you know, at least I found myself thinking, okay, I'm going to take my business and support and do takeout on this restaurant that is not a huge chain, right? But like, you know, be mindful of where you take your business. And in the ideal world, in my mind, I think that also happens with healthcare. You know, who am I supporting? Am I going to bring my good insurance healthcare dollars to the hospital that just is mistreating, you know, certain groups, or versus I'm going to support this group that does a good job and provides good medical care? You know, so little decisions like that, I think matter and make a difference as well.
Yes. And speaking of the pandemic and so much more virtual or telemedicine that's being offered, do you think that has helped bridge some of the gaps for folks that are in the rural areas, or maybe not, they don't have the transportation to get to a particular clinic, but they're still relying on technology? What are your thoughts in terms of how that might have helped or created another avenue that we need to work on?
I think it has been great for very specific things. I still think that oncology care does require that face-to-face connection to walk that journey with each person in front of you. But then there's many instances where telehealth has been a godsend. In particular, I think, for example, genetic testing has been greatly benefited with telehealth. You know, the genetic counseling portion, instead of having to travel to these 2 places in the state that do this type of service, that you can do it over telehealth. I mean, I think that has been huge. There's still so many things that require in-person visits, right? Infusions, radiations, or just that doctor appointment where, you know, just having that connection might not. Telehealth, I don't think, will replace any of that, but there's many instances that it will. Psychosocial counseling, I mean, like so many patients that needed counseling services or behavioral health services before. It was a huge barrier, but now with telehealth, it's much more doable. So behavioral health, genetic testing have been greatly benefited.
Wonderful. Are there any other questions that you would like to ask Dr. Okuyama? There's quite a bit of commentary in the chat, Sonia, that really expresses all of our gratitude for the work that you're doing in the presentation today and helping us both be informed and inspired, not only to know this information, but to use it in each of our respective practices to move it forward.
Yes, thank you for having me. There is a lot of comments, and that's exciting. It means that people are engaged. I mean, again, I think every single person in their heart wants to do the right thing, but you know, the system's just very difficult. But you know, that will be a work in progress, but we'll get there. Maybe not in my lifetime, but we'll get there.
Yes, agreed, and that, as long as we continue to listen to understand our patients and the individuals that we work with and be able to help them reach across those chasms that we've created in our institutions and be willing to be that facilitator of change as well as to carry your message forward. So thank you. Thank you very much. As we wrap up today, do you have any other resources that you might direct our participants to go to as far as a website or a book that will help to keep them informed and inspired as we go forward?
I'm drawing blank on that one. I really think social media is where it's at. You know, Twitter primarily is where a lot of these angst and conversations seems to pop up more frequently. There's several folks that I think are worth following that talk about health disparities, and but that's where it is. It's just interesting where the conversations are. It hasn't reached the medical journals yet, and much less books. It's on Twitter.
Yes, I would agree. And one story at a time, right? So, all right. Well, just a reminder that if you're in the Colorado area and you want to be part of this coalition, please go to the Colorado Cancer Coalition and select the link for the Survivorship and Palliative Care Task Force. We're happy to have you be part of our group and this discussion as it moves forward. And our next meeting is May 25th. We usually meet on the fourth Tuesday every other month. And so we look forward to hearing from you, welcome you to join us, share your thoughts, help us know what kinds of information you need and want to move forward. If you're outside the Colorado area, we are very glad that you joined us today, and you're still welcome to reach out to us with any thoughts or invitations for us to participate into this larger conversation across the country. So thank you very much for all of your participation in this effort. And thank you again, Dr. Okuyama, for your work. And I hope that you'll continue to let us know how we can help you going forward. You know how to reach us, and let's keep it an open, active conversation.
Thank you.
Yes, awesome. All right, without further ado, we'll wrap up today. Carlin, did you have anything else? Nope. All right. Well, thank you, everyone. Take care and be well, and keep up the good fight.